Good afternoon. My name is Julia and I'm from the Wagga Wagga Clinical School. Today I'll be presenting my ILP, which is on measures to increase the utilisation of the paediatric clinical practice guidelines in emergency departments within rural and regional New South Wales. The guidelines of focus for my project are the New South Wales Health Paediatric Clinical Practice Guidelines, which have been published in recent years. These guidelines aim to standardise patient care when treating these 11 conditions. A study conducted last year researched the barriers to the utilisation of these guidelines in rural and regional New South Wales. They found compliance to be suboptimal at 52.1%. Their research indicated that the top 4 barriers to utilisation was there was a lack of awareness of the guidelines, there was a lack of access to the guidelines, there was inadequate education and training regarding the guidelines, and that the guidelines were too complex. Our study aimed to develop and deliver a multifaceted educational program to all the 10 emergency departments within the Murrumbidgee Local Health District to hopefully increase compliance. It is important to note these 10 hospitals are the exact same that were researched in the initial study. We then plan to re-audit all paediatric presentations within a 3-month period using the exact same techniques and audit tools as the previous study to determine if compliance had increased. This map illustrates the central regional location of the 10 hospitals located between Sydney and Melbourne. More specifically, these are the 10 hospitals that were included in the study, with 2 of them being base hospitals, Griffith and Wagga Wagga, and the other 8 being district hospitals, with Leeton, Narrandera, Temora, Juneen, Cootamundra, Young, Tumut and Gundagai. The educational package we created was aimed to specifically target the 4 barriers previously identified. The package consisted of a copy of the guidelines in printed books, as well as electronic copies saved on desktops. We also placed desktop reminder stickers on all computers and keyboards within all the emergency departments. Quick response codes for each guideline were also generated to allow easy accessibility on a smartphone at the point of care. We also created and distributed an information sheet on the guidelines to all the medical officers who work within these emergency departments. The following pictures are examples of what we included in the package. There's an A4 poster reminding them of the guidelines and what conditions they exist for. An example of a QR code we made for bronchiolitis, so all medical officers can scan that and have them on their phone. And the desktop reminder sticker that we put on all computers and keyboards. This is the summary book that we gave out to all emergency departments. They included the summary flowchart of all the guidelines. 3 months post the implementation of the educational program, we conducted a retrospective audit. We reviewed all paediatric presentations to the emergency departments, which were consistent with the New South Wales Health Guidelines. We determined compliance using a 5-point scale to analyse each case presentation and if the management was consistent with its guideline. The 5 criteria we looked for in the medical record included vital sign documentation, provisional diagnosis, investigation and initial management, treatment at the time of discharge, and any indication of a follow-up need. Each point was scored out of 1, and a total of 4 or 5 was deemed compliant. This was the exact same audit and tool that was used previously in the initial study. Overall, there was 1,335 cases within a 3-month period that was consistent with the guideline. We found compliance to increase from 52.1% to 72.8%. Significance was assessed using a chi-square test that gave a p-value of 0.0001, demonstrating a statistically significant increase. This figure demonstrates the variability in the number of case presentations with each guideline within the 3-month period. It can be seen there were large variations, with fever accounting for 235 cases, whereas bacterial meningitis only accounted for 1 case. This figure illustrates the change in compliance for each guideline post the implementation of the education program. It can be seen that compliance increased for 9 of the 11 guidelines, with 6 of these being statistically significant for the cases of abdominal pain, gastroenteritis, asthma, bronchiolitis, fever and sore throat. Compliance, however, decreased for two of the guidelines, croup and head injury. We found the majority of non-compliant cases of croup were due to mild croup being pharmacologically treated with glucocorticoids. Whilst this is not recommended in the New South Wales Health Guideline, a Cochrane review published in 2011 had results confirming that dexamethasone is effective in treating mild croup. This discrepancy could account for the differing treatment options medical officers choose to follow. Head injury compliance decreased from 73% to 61%. The majority of cases that were deemed not compliant were mild to low-risk head injuries where observations were not recorded in the medical notes and therefore they were deemed not compliant. It is important to note for these non-compliant head injuries, many of the patients were given advice and fact sheets to observe for any signs of deterioration, which is in keeping with the guidelines. We further analysed the differences between compliance and the type of hospital. It was found base hospitals generally have higher compliance rates. However, it can be seen that both types of hospitals' compliance increased significantly post the educational program. We did not attempt to determine why these differences occur. A number of factors could potentially contribute. There are considerable training differences between the base and district hospitals, where base hospitals employ permanent emergency staff specialists and paediatricians, whereas it's very different in district hospitals, where the majority of medical officers are visiting and do not have specialist training in emergency or paediatrics. Our study demonstrated that a targeted educational program can significantly increase compliance with multiple clinical practice guidelines. We believe that this is likely to result in improved outcomes for all sick children presented to emergency departments within rural and regional New South Wales. I'd like to thank the following people for helping me over the previous year to complete this project. And this is the reference for the initial study that was conducted last year.
Thanks, Julia. Okay. Papers now open for questions.
The first question relates to your last slide, which said that this improvement should improve outcomes. What's the basis for making that statement? And the second question is whether you've got any evidence or any reason to think that this very impressive effect is going to be sustained.
Clinical practice guidelines are made and have been shown in literature to show improved outcomes for when they are followed. They are also focused on increasing the effective use of limited resources, but in other literature it is shown that when they comply with guidelines there is significant improvements in patient care. And we think this translates well with the paediatric guidelines and paediatric care in regional and rural New South Wales. For the long-term benefits of this research, we are not sure. We can comment on it does have short-term benefits, as within the 3-month period it did show marked and significant improvements.
Thanks very much. Congrats, that was great. Kind of interested to know what you think has led to the improvement, because there are a number of things that you've done there, including producing a document. Do you think your study would have been strengthened with the control group who didn't have a document, but so you heard of the fourth-one effect? So you study the group, just look at them, they will improve. So the question is, I suppose, what bit of the intervention do you think was useful, and whether the control group would help you decide which bit of the intervention was useful?
A control group would have been very helpful. I find within the scope of the ILP there probably wasn't enough time to do that as well. But sorry, I forget the other part of your question.
No, that's fine.
Okay.
Two more questions.
I've got two questions. The first one's brief, it's just whether both the audits done at the same time of year.
No, the initial audit was done over a year-long period, and mine was done within just the 3 months post the intervention. So there was a recommendation to do a pilot study prior to when we did the education program, but again, within the scope of the ILP, we found that wasn't viable to complete.
Because depending what time of year is that can also influence, the knowledge of the junior residents.
Yeah.
On the laws, I'm not sure if yours was that towards the end of the year or the middle of the year.
Yeah, and we found that there would have been great variation in the number of cases presented with seasonal change, especially with asthma. But that's enough.